Councillor McCabe wasn't able to join the first meeting. He might be held up somewhere.
Yeah, so I'll ask him to start.
Okay, I'm happy to start. Is everybody ready? Yeah. Are we streaming?
Yeah, they're ready. Yeah.
Okay. Good evening, everyone. I'm Councillor Colin Steers. I'm the chair of the South West London and Surrey Joint Health Scrutiny Subcommittee, Improving Health Together 2020-2030. It's on this 22nd of October 2020 meeting. Welcome to this virtual meeting. The Vice Chair of the committee is Councillor Bill Chapman, and he will take over chairing of the meeting should I lose connection at any point. The meeting is being live streamed. Following this meeting, it will be available on the Council's website. I'll mention a few key points here that will help us have a successful meeting. When you are not speaking, please turn your camera and microphone off, as this saves bandwidth. You will appear on screen when your microphone picks up a sound, so this will save the stream cutting to different members suddenly. I should allow plenty of time for members to speak on items and shall make this very clear as we move through the agenda. Therefore, please only speak when I call you to do so. When you speak, please turn on your camera if you are happy to do so. When you speak for the first time, please state your name clearly before you begin. Councillors should introduce themselves with their title and name. Officers state their name and title. If you want to raise a point during the meeting, please use the chat box found in the top right of your screen, where you can type questions during the meeting. I will monitor the chat box at the meeting as it progresses. I apologise now if I miss you. I might have to come back and pick you up. Could I ask members to indicate in the chat box if they are declaring any interests? As we begin this meeting, I shall ask all members to state that they are present as the clerk moves through the alphabetical roll call of members and substitutes. If you are present in the meeting but you have your camera switched off, please state this clearly. Kathy, would you please call the roll?
Okay, I can see in the meeting that we have Councillor Bill Chapman, Surrey County Council, Councillor Fitzsimons, Croydon Council, Councillor Anita Shaper, Kingston Council, Councillor Adrian Fluck, Wandsworth Council, Councillor Colin Steers, Chair, Sutton Council, and we're waiting for Councillor Peter McCabe, which we at the moment. And then as experts and attendees of the meeting, we have Sarah Blow, Accountable Officer, South West London CCG, Dr. Russell Hill as Joint Chair, Surrey Downs ICP, Andrew Demetriatis, Programme Manager, Improving Healthcare Together, Daniel Elkerley as Chief Executive, Epsom and St Helier Hospital, Charlotte Caniff, Clinical Chair, Surrey Heartland CCG, Trevor Fitzgerald, BYFH Programme Director, Dr. James Marsh, Deputy Chief Executive at St Helier Hospital, David Olney, Scrutiny Officer, Sutton Council. Thank you, Chair, and I can see no declarations.
Thank you. Can I welcome you all? Can I also welcome those residents and other people that are looking at the screen? Thank you very much. Do we have any apologies for absence?
So none received.
Okay, and you've had no declarations of interest?
No.
Thank you. We now move to the next item on the agenda, which is the minutes of the last meeting. Members, we can approve the minutes of the previous meeting held on the 4th of June. I'll allow time for members to speak if they wish to express dissent on the minutes. Members, if you are happy to accept these minutes, please comment in the chat box. And I am aware that as part of the minutes of the last meeting, on page 3, I think, page 2, there was a question that people were going to report back. This isn't matters arising, but we asked people to report back regarding the referral to the Secretary of State. So I'm happy for those to report back as we said we would from the last meeting. So colleagues, councillors, if you want to come in there, please. Councillor Fitzsimmons, please, over to you.
Okay. So thank you, Chair, for the chance to report back. I'm just bringing up on my other screen the conclusions of the meeting we held in Croydon at our Health Scrutiny Committee on the 22nd of September. And for the record, so that I get it correct, the committee, Croydon's Health Scrutiny Subcommittee considered the matter of whether to refer this issue back to the Secretary of State. We looked at the paperwork that had been produced by the Trust, but also looked at the work that Merton Council has done, and we made the following cross-party conclusion. The government investment in the local health economy was welcome. Many of the concerns set out by the London Borough of Merton in its submission to the Secretary of State were echoed by our subcommittee, particularly those regarding the accessibility of the preferred site and the possible equalities implication of the decision. The subcommittee agreed that it would endorse the referral made by the London Borough of Merton and keenly awaited the outcome. And it was agreed that the Chair would seek to explore the possibility of the subcommittee of South West London and Surrey Joint Health Scrutiny Committee reaching a joint conclusion to endorse a referral made to the Secretary of State of Health by the London Borough of Merton. I'm just reporting that as a matter of fact, and I'd ask that to be put into the minutes of the meeting. Thank you.
Thank you, Councillor. Would any other councillor like to make a statement of fact where they stand on this? Councillor Shaper?
Yes, thank you, Chair. It was just to say that at full council last week at Kingston Council, we did vote on the repatriation of the right of referral to our local authority, Kingston Council. So the repatriation has taken place and was duly voted through at full council last week. Thank you, Chair.
Thank you. Before I move on, could I welcome Councillor McCabe into the meeting? Thank you. Councillor Chapman, did you want to comment on the Secretary of State's referral, or not, as the case may be? You're muted.
Chair.
I'll come back to you, Peter, if I may. Councillor McKay, Councillor Chapman, you're muted. Kathy, could you see if you could add technical support to help Councillor Chapman?
Yeah, yes.
Thank you. Councillor McKay, Peter, yes, please come in.
Well, I just missed the end of Sean's remarks, or I came in as he was speaking, so I missed the beginning, I caught the end, and I assume that people are aware that Merton has made a referral to the Secretary of State for Health. You will recall that at the very beginning of this process that we reserved the right to do so. We felt this was an issue that had a very serious impact on our residents, particularly those living close to St Helier Hospital and the deprived communities in that area. And I think Sean has kind of referred to the issues, and it is a matter of record what our concerns are. We have explained them at length to this committee. I'm not going to go over them again, but we feel very strongly that this matter has not been well handled. It will be to the detriment of people in Merton, also in Sutton, where the St Helier Hospital is currently situated, and in surrounding areas, because, as I've said repeatedly, when the people of Merton find that the new site is
Peter, because we don't do matters arising, this is just a statement of fact about where your council stands with referral to the Secretary of State. Well, I think we're very clear and very clear on your reasoning as well that you put forward as a council.
If I could finish the point, Chair, we think it has an impact on surrounding hospitals and on surrounding, and that's why I think Croydon have supported us. We think it will have an impact on St George's and less so with the other surrounding hospitals, but certainly those two in particular.
Thank you, Peter. Bill, Councillor Chapman, did you want to come in? Are you able to come in now?
I am, yes, thank you. Yes, sorry, do not wish to refer anything to the Secretary of State. Thank you.
Thank you. And just state Sutton's position. Sutton's position is that the referral to Secretary of State is embedded with the council, but no decision has been made as such. So that's just a statement of fact from the boroughs that have been participating in this scrutiny process for some time. Thank you very much. If we could now move on. So they're the minutes of the meeting. I'll take the minutes as approved if everybody's approved them. Is everybody okay? If you remember, if you want to talk, you can, or approve thinking, please use the chat box, which is the top right, the green box. So I'll sign the minutes outside this virtual meeting when social distancing restrictions are lifted. I can't tell you when that is. So please, if we could move on to agenda item 5. Now, this is the update from the Trust and the Commissioners, which I propose to take in 2 parts. The representation and the presentation from the Trust will be first, and then councillors will be able to ask questions of the Trust, and then we will move to the presentation by the Commissioners, and councillors will be able to question the Commissioners on their part and their presentation. Could I now turn over to Daniel Elkleys, Chief Executive of the Epsom and Helier Hospitals Trust. Over to you, Daniel.
Thank you very much, Councillor Steers, and good evening to you all. You're not going to hear so much from me because I'm going to hand over in a moment to 2 very amazing people. So Trevor Fitzgerald, who is the Director of Estates at Epsom and Helier, and has spent the last 20 years of his career sticking St Helier back together again as far as it's possible. But now he's the Programme Director for the new hospital. And also James Marsh, who you've seen and met several times, who is my Deputy and Medical Director. So we are completely conscious that Merton have made the referral to the Secretary of State and the IRP process is happening. So we're going to tell you about process of where we have got to, and nothing we have done would undermine whatever the IRP might say, and we hope that they do report at the end of the month as planned. And we've written you a Word document, so we're not going to put it on the screen. We're just going to talk to the various sections of it. And the bit I just wanted to begin with was to remind you that we've been at this for a very long time. So in section 2 of the document, in 2017, Epsom and Helier put on the table that we really thought that we needed a new hospital and explained our rationale for that. Then in the next almost 3 years, the commissioners took on the mantle, and so Sarah and Russell and Charlotte and Andrew Dimitriades led the process from the commissioners' perspective. That was the Improving Healthcare Together programme, which you all know all about. And then when they made their decision in July, they handed it back to the Trust to say, now please get on and implement our decision. So we've called the programme Building Your Future Hospitals going forward. And at that point, I'm going to hand over to Trevor to start taking you through the paper.
Thank you, Daniel, and hello everyone. Obviously people will be aware of the Commissioner's decision-making business case, where it has made it clear that that we are adopting the clinical model for the delivery of the district hospital and also a special emergency care hospital. That the special emergency care hospital should be located in Sutton, and that we are to adopt the recommendations of the implementation. I think it's fair to say that there's a number of recommendations that have come along with that decision-making business case. So we are working closely with our commissioners around a number of providing assurances. And I think it's fair to say that although the assurance may take some time to deliver, and from now up to our proposed delivery of a new hospital in 2025, we're working with our commissioners around how do we implement and deliver that. And some of those core areas that we're working on is around learning from changes to COVID, and you'll hear a bit more about that as we go on. Ensuring that we make sure we use best use of digital health records. We implement and further develop the clinical model. We obviously have a lot of focus around the workforce. We need to make sure that we're planning and working to deliver the needs of the future bed requirements, and you'll be aware that the minimum requirement is 10,066. We obviously need to stay within a financial envelope as well, and that's important that we're working on that. There's work around making sure that we do everything we can as a large employer and running large buildings, that we just have sustainable development in our buildings and in how we undertake our services. There's work looking at how we can improve access to primary care, and looking at whether there's opportunities to deliver primary care on the St Helier Hospital site, along with other potential community services that we're working with in the CCGs on. I think we're all very aware that one of the key issues that we have to work on and focus on is travel and access, and I'll come on to that in a bit more detail in a minute, along with further work around deflation, health inequalities. There's also some work that we're being asked to do to look at renal inpatient provision and further linkage with social care. So there's a lot of work that needs to be carried on along those actions, and I think over the course of the next year or so, we'll be working with our CCG to provide assurance and more information around that. As Daniel mentioned, we've moved into an implementation phase and handed to the trust to deliver it, and we've called the programme Building Your Future Hospitals, and I think it's very important that we see this as providing free hospitals for our population. So in addition to the new hospital, we are still very clear that we need to maintain, develop and improve both Epsom and St Helier hospitals, and that's the key message we've been working on. So we set up quite a robust governance structure within the organisation, and I think you've seen the organisational chart. I won't go into a lot of detail, but ultimately we have a trust board that are reviewing all of our work, that will actually feed into our regulators, but also the strategic oversight group, which is part of the local commissioners' assurance process. Below that, we have a subcommittee of the trust board, which is the programme board, and that's meeting monthly and has most of our exec directors, but also all of our non-executive directors on that board, along with a representation from the CCGs and also NHSIE. So there's that overarching governance to have assurance around the work we're doing. Obviously, there's an awful lot of work undertaken, and we've undertaken a whole range of work streams to focus on that work. So we start off with the clinical work stream, and you'll get to hear a bit more about that very soon, to look at further refinement and work around the clinical model that has been requested to be implemented. And very closely with that then helps us work on what our workforce model and requirements are for the future. I think everyone's very clear that obviously these changes also have an impact on our providers. So there's a specific work stream that we are doing to work with them to make sure everyone's cited on that, we understand the implications, and we're all prepared for those what's needed in the state's terms for 2025. Obviously, a large amount of work is around the estates work stream, and we split that into two: one focusing on the new hospital, which I'll come into more detail with, and one focusing on the two district hospitals, Epsom and St Helier. There's obviously a large piece of work that we're focusing on commercial. Obviously, we're looking at spending a lot of money with construction contractors around the new hospital, but also the significant investment that we're putting into St Helier and Epsom. And as we mentioned earlier, around the electronic patient records, there's a technology work stream, but not only just looking at new electronic patient records. What we want to make sure is that we have a state-of-the-art digital enabled buildings for the future. And then lastly, obviously a focus around strategic focus that we need to do to make sure that we're working with all of our partners and that we continue with the strategic direction that's required. So there's a large amount of work across all of that in terms of getting into the implementation phase. And we've actually undertaken a mix of using in-house or employed Epsom and Helier staff such as myself to work on the programme, but obviously there's a number of work such as architects, designers, healthcare planners that we've actually used some consultants to support us on that piece of work. I'll pass you over to James Marsh now, just talk about start talking to you about COVID.
Thank you, Trevor. For those of you that don't know me, my name is James Marsh. I'm a renal physician based at Epsom and St Helier Hospital, and I'm the Deputy Chief Executive and Joint Medical Director. It's clear that we need to incorporate any key lessons from the recent pandemic into the clinical model that we're developing for the service. I think there are 4 key headlines of lessons that we've learned clinically through COVID that are probably pertinent to this programme. Firstly, it's really important that our buildings are flexible and can respond to surges of demand of very sick patients. And what was very clear from the first surge of COVID was that we need to have the provision to significantly increase at relatively short notice the number of intensive care beds or facilities that we can offer, and the ability to ventilate with mechanical ventilation very sick patients. Secondly, in line with developments happening across London, it's important that we can give confidence to patients and our staff that we can separate out planned care pathways from emergency care pathways, so that patients who might be infected are kept well away from patients coming in for planned care, such as planned operations. In addition, it's important that on emergency pathways, that we can, within hospital buildings, we can design this space to allow suitable segregation of patients who we suspect may be carrying an infection from those who we don't suspect have any infection. Thirdly, it's very important that we have resilient staffing. We know that under our current model of care, we have some challenged aspects of providing resilient staffing for some of our emergency care pathways. And it's important in future pandemics to have flexible staffing that are resilient and consolidated in areas of greatest need. And then a final key lesson that we've picked up is that we can deliver more care remotely if we have very good digital technology. So we can provide outpatients digitally, and we can also provide a lot of back office function remotely. So we don't need to pull so many people into the physical workspace, and we don't need to bring patients to face-to-face appointments if it's not offering added value. But it's important that this is backed up by good digital technology that supports clinicians and our administrative staff to offer the best quality care and to communicate effectively with our partners, whether they're in secondary care, primary or community care, and clearly, really importantly, with our patients and service users. So these areas will be explored further through the business case process as the plans develop and we develop our pathways in a more detailed way and building designs. But in some of the early work that we've undertaken, in order to improve resilience, we've increased the number of intensive care beds in our plans. We've increased the proportion of single rooms in the ward areas from a baseline of 50% in the pre-consultation business case to just over 70% single rooms at the Sutton site. And we've highlighted the additional capital requirements through the HIP1 regulator process. We continue to participate, contribute and learn from the other HIP1 schemes in regard to changes that are implemented to support resilience for future pandemics. I've mentioned digital technology. We've completed extensive work over the summer and created a combined strategic outline case for the purchase and implementation of a new electronic patient record. This was signed off by our board in September and submitted to the regulators for approval. Our trust board has agreed to progress to a full business case immediately, with the expectation that this will be completed in the spring next year. In terms of the clinical model, we've engaged extensively over the past 3 months. We've held over 60 workshops with clinicians, over 180 clinicians, including doctors, nurses, allied health professionals, and managers. Clinical engagement has run in a number of phases as we've iterated the clinical model, and we've provided a sense check through a clinical advisory group through our clinical leadership community, and this has involved representation from different types of professionals, but also primary and secondary care. The write-up of the clinical model is now in progress and will be included in the clinical chapter of the outline business case. In association with this, with activity and financial modelling, we've created a workforce baseline model. And again, this needs to iterate as the clinical model becomes finalised. The model's been updated simultaneously as part of our clinical engagement workshops for the future ways of working. And we're currently reviewing these requirements across the programme. So I'll hand back over to Trevor, who's going to talk about the finance and activity.
Thank you, James. So as we mentioned previously, that the commissioners have made it clear that the trust needs to plan to deliver 10,066 beds. Because obviously we're conscious that we need to make sure we're building a hospital of the correct size and also provide a provision in district hospitals. We've underdone further work on that activity, and currently with the small changes that we talked around COVID, etc., we believe there's a small change of an additional 3 beds. So currently we're planning a size of 10,069 beds. So it's a small change. I think this is very important because once we've worked out the activity, the beds and also the other activity will go there, that then helps our healthcare planners turn that into a schedule of accommodation, so the space requirements needed. And it's important for the specialist care hospital that that will all be in compliance space-wise in terms of the health building notes, which is a standard that the NHS requires to meet to. That provides us with a square meterage, and then obviously we can then design the actual hospital to meet that square meterage, and then that eventually provides us with more robust capital, which we're working on. So I think we mentioned previously that there is a small change in terms of the capital requirements, and we've highlighted and working on that to make sure that it's still affordable and within the financial envelope. Moving on to the actual business case and building design options. So in terms of the new hospital, I think it is important to say that I think most people be aware, but it's actually on a site that is a larger part of the site shared by the Royal Marsden Hospital, the Institute of Cancer Research, and also London Borough Sutton and their ambitious programme for the London Cancer Hub. And one of the piece of work that we're doing and ongoing is making sure that all 4 partners on that site are happy with the master plan of access and land ownership and how all services will work and link onto that. And obviously it's very important for Epsom St Helier to be very clear on the work that we're doing with the Royal Marsden to make sure we've got that clear linkage and clinical adjacencies, which is really important for our patients. The building work that we're doing at the moment is looking at, from that side, is actually doing a building mass, and so we can understand the size and the cost of that. We've got some very clear, sorry, I've got some sound qualities. I'll try and come close to the mic. Hopefully that's better. We've got some very clear direction from the NHS around we have to build this building in a way that it has a net zero impact on carbon. So that's really important. But we're also aware that we've got to do a lot of work to have the support of our local council and to ensure that we achieve the planning permission requirements. So currently we're working on to what we call 1 to 500 scale drawings and sort of working around the clinical adjacencies where services would go. I did mention earlier around the synergies working with the Royal Marsden, and we're doing a lot of work at the moment looking at the benefits of synergies around haematology, oncology, paediatrics and pharmacy, to name a few. But there's also a lot of opportunity for us around our back office shared facilities, and that work continues. I think I mentioned it earlier, but we're very clear that we have a lot of work that we want to do at our district hospitals. I'm sure everyone will be aware of the significant investment and construction work that we are doing at both Epsom and St Helier Hospital, because we are clear that we continue to provide healthcare service from that, and we need to continue that investment. And as part of this programme, we do put a significant amount of investment into those buildings. So we're working over the coming years to look at how can we address our backlog maintenance, what are the changes that we need to provide those healthcare facilities, and along with, as I mentioned earlier, looking at how can we support primary care coming onto site and potential other community services to join us. So with that work going on, I think very clearly we've got a lot of work around the travel and access to undertake, and it's on the Sutton site. We know very clearly there's a lot of work to do around transport and access and addressing the congestion around local residents, roads, etc. And I'm pleased to say that we are working very closely with the London Borough of Sutton officers and also the other partners, and we are all working jointly of how can we come up with a solution to provide suitable access, but also try to reduce congestion on those roads and improve access for all. Part of that work obviously is very much around improving public transport improvements, and I'm sure most people will be aware that TfL just started a consultation around bus improvements to the Belmont site, which is most welcome, and I think it provides much improved links, certainly from the Merton side. But we do know that we've got to do more work on that. We've got to look at our Surrey catchment and how can we improve linkage around that. And as we move forward, we'll be very clear of how can we have reference group with our population and key stakeholders to actually work with them on what those needs are and how we can best meet them. I think we know that there's a lot of construction happening on the site at the moment. We know that the Royal Marsden are delivering their Oaks outpatient centre, and you know, there's a lot of work that we're doing of how can we undertake large construction, but at the same time also coordinate that with the future developments that Royal Marsden want to undertake, the Institute of Cancer Research, and of course the ambition of the London Cancer Hub. Just going back to the district hospitals, you know, we are taking on top of the community services we talked about. We are undertaking some conversations with Rose Hill Ambulance Station around potential of solution of coming onto the St Helier site. And I'm not sure everyone's aware, but Epsom St Helier runs its own non-emergency patient transport services, and we have over a fleet of 60 vehicles. And we see there's some synergies with the local NHS joining around maintenance of vehicles, wash facilities, etc. So that's very much work in progress, but it's a potential benefit. We know that some of our enabling schemes that we're also looking at is providing a multi-storey car park at Epsom, and that's part of our planning application process currently going through the Epsom Ewell Borough Council. But we're also pleased to say, on top of the works that we're undertaking at Epsom, including the external refurbishment of Wells Wing, that we've secured funding to upgrade and relocate to provide a fit-for-purpose stroke ward for Epsom Hospital. And at St Helier, we've secured enabling funding to improve our inpatient renal facilities into our main building, because they're in very poor condition environment at the moment. I think the other thing that I just mentioned, going back onto travel, is that we see we've got two pieces of work to undertake, and that's obviously in terms of working with the London Borough of Sutton and also GLA around the transport issues for actually accessing the special emergency care hospital. But also there's the wider piece of work that I mentioned earlier with our commissioners and also key stakeholders around how can we improve access to all of our sites. And I think we still have that commitment where we mentioned that actually the Trust actually runs a public transport service that is linked in with our staff provision, and we'll be looking at extending that to ensure that we meet the needs of our population. Just one last thing from me before I move on to Daniel is around other providers. So we are clear that there is some impact on other providers around our catchment, and we've been working hard with them to secure what already we secured, £39 million of investment into the estate of those hospitals. So that's a good achievement in itself, but we're aware that we need to then firm up those plans with our other providers to make sure that they're robust and they can be delivered within the timescale that we need them to be, which is 2025. And we've been working with them on the activity modelling and really pleased with actually the support and engagement that we're having on that work. So that's it for me. I'll pass you back to Daniel.
Thank you, Trevor. So just picking up the other provider bit. So the two providers where there is the biggest impact are Ashford, St Peters and St George's. So we have put most effort into with those two providers, and it looks like it is on track, and both those providers can put in place the capacity that they need for the money that was allocated to them. So that is looking very positive. The comms section is quite easy to cover because you'll see it's nearly all internal, because until the IRP process has finished, we don't think it's right to be talking to the public about what we're doing because the IRP might come up with other recommendations. And then lastly, there's a lovely timeline right at the end. And if all goes to plan, then we think we'll start having construction of the new specialist emergency care hospital in February 22. And it will be complete for Q2 2025. So we are on track for having new hospitals open in 2025, and then we can start finishing all the work on the two district hospitals in 2026. So this is a very ambitious timescale, and currently we're going on track. And I think that's the end from us for now, for questions.
Councillor Chapman, I think Councillor Sears is asking you to take the chair.
Oh, okay, fine, thanks. So I think we can throw it open to questions or comments from councillors.
Okay, over to you, Bill. I'm back now.
You are. Okay, go ahead.
Okay, so thank you very much for those presentations. And we'll throw it over. So if councillors have got any questions, first question is from Councillor Shaper.
Thank you, Chair. Thank you, Trevor. Thank you, James, for the presentations, and Daniel. What I'd like to do, if you don't mind, is I'm just going to do a brief comment overall, just to really take you into three strands, and one question at the end. So there is a logical reason why I'm doing this. So really overall is an observation that clearly this is a complex programme with clearly 9 work streams within that governance structure. I can see exactly from the governance structure why you're adopting this way of doing things, because you've clearly got a mixture of clinical estates and all other aspects of this programme to cover. So it's obviously very complex, and you've broken down your work streams with all the relevant stakeholders, etc. in there. So where I'm coming from is where you've touched on digital and the workforce modelling, that simultaneous element of it, because this is a moving situation. So I do appreciate that. So where I guess where I'm zoning in on specifically is 3 strands. One is where you talk about the primary care community service, because the way I see it, as your clinical commission group have the oversight, part of the oversight with your executive team and so on, clearly there is an element here that you obviously have strategic planning involved. You have the idea that you've got additional services that you could offer in the primary care and community area, but that's not really fixed right now, because where I'm looking at the from a strategic point of view, I can see it's an aspiration, and where it's sort of been referenced, where you're trying to involve the community more. You've got that idea of health prevention and early intervention. I understand that. We want to bring that, the additional possible primary care and community service to St Helier. I can see that from the documents. So where I brought it into my comments is part of that really is interdependency between the work streams, and my concern is about timing. So when I look at and you mentioned, Daniel, the word ambitious, it is ambitious, and looking at the timing, my concern at this stage is that when I read these papers, 2 things strike me. One is that my expectations have been that by now I probably would have wanted to see that McDonald review, because part of that recommendations that you've highlighted on, you've mentioned 24, but clearly one of them, recommendation, 17, it's the one where you've got the McDonald review, 17 and 21. Clearly, and I'm sure some of my colleagues will touch on the access issue, but for me, those interdependencies are so crucial at this stage, because you're entering a critical phase. We've got 12, 13 weeks between the outline business case. And my concern is it is ambitious. And if you've got any element of community, the word community, for me, is about engagement. And I haven't really seen any evidence as yet, apart from the 60 workshops that you've run, where you can cover off that element within the next 13 weeks. I hope you can. So that's one aspect of my concern, is the timing. And I would really, by now, would have liked to have had that McDonald review. I think, bearing in mind, I know we've had, the 3rd of July, but since then, really, since you were handed that sort of, that what you said at the beginning about the responsibility, I would have liked to have seen that really in my midst right now, because that would have given me a bit more of a steer as to where you're at for your, for your outline business case. So that's one concern. And I think the other concern is just touching on the primary care and community. It's the wording is I find a little bit ambiguous, because you're talking about it being appraising additional services. So you're not quite sure at this stage what that looks like. And that worries me a bit, because I think at this stage, if you had got the engagement down and, you were kind of in the thick of it, you probably would I'd like to have known what sort of feedback you'd got from various stakeholders in the community about what they would like to see in there. and it's not clear whether it's a definite or a possibility. So I think I've just got a few question marks about those aspects of it so far, and I wondered if you could just sort of tease that out for me. Thanks.
Shall I try and start that? I think this might be a multi-person answer. On the bit about additional services on the St Helier site, one of the inputs into the decision-making business case from the commissioners was Merton and Sutton councils writing to say, would you consider putting any additional services onto the St Helier site? And there is a piece of work which I'm sure when you get to the second part of the meeting, the commissioners can say this is the work they are doing to scope out what those services could be. And the timeline for doing that fits with the timeline for us doing the outline business case, so we can take the output from that and put it in. So I'm not so that bit feels like it's on track and will work. In terms of the wider engagement, this is more complicated because, as I said, we essentially we thought we should wait until whatever the IRP concludes, because we don't want to prejudge that we're just getting on and doing everything as if the IRP wasn't happening, when Merton have quite reasonably said that they want a review process. So there is quite a lot of flexibility in the way the business case process works between the outline business case and the full business case. So providing the engagement that we do doesn't fundamentally change what we put in the OBC, it will be perfectly possible to make adaptations to it in the elapsed year between the outline business case and the full business case. And actually, in some respects, the delay in being able to do engagement is helpful from the IRP, because we can actually go with more firm thoughts about what we think the things are that we want to talk to the public about. So it may not be a problem, but do accept that we do need to do some public engagement on our thinking and what to get people's input into it. I mean, it's probably one of the biggest investments that is happening in the public sector in southwest London and Surrey. So it would be remiss not to get lots of input into what the design should look like and what it needs to be and feel like for the public and patients who are going to use the facilities. I don't know whether James or Trevor want to add to that.
I think if I just come in quickly, I think you covered it, Daniel. I think just in terms of the work around the 24 recommendations and continue with what McDonald work, I think I'm very clear that we don't want to rush that and undertake that work by Christmas. I think it's a longer piece of work that we need to work with our commissioners on in delivering, and we have to bear in mind that these service changes are looking at in 2025, and so we do have some time to make sure that we adapt and look at our healthcare service. You know, we adapt our healthcare service and change services regularly. So I think there is a piece of work about let's not rush everything now and then close that down. I think it needs to be a process where we are listening, we're adapting our plans, but it's a continuous process rather than having a drop dead date.
Councillor, I'll come in if I may. I'm sorry, I missed everything that you said. I lost my internet connection, so I apologise if I go off at a tangent. But part of the workshops that we've been undertaking have included community and integrated care, and we have engaged with our GP colleagues and our specialists within the trust in terms of acute frailty and ongoing integrated care into community services. But we absolutely recognise that things do need to iterate and evolve, not least once we have the opportunity to engage more formally with our public and wider stakeholder community. I think one of the key lessons from COVID is that we absolutely need to create flexible workspace and the ability for agile working. the healthcare landscape has changed quite significantly over the past 6 or 7 months, and the degree of collaboration that we're seeing between providers has really taken off at a huge pace. So it is quite exciting to see that there are increasing opportunities not only to work with our acute providers, but to work in a much more integrated way with primary care and community care. And we look forward to ongoing discussions with stakeholders to iterate the plans.
Thank you very much on that one. Councillor Chapman, and then Councillor Ambash.
Thanks, Chairman. Yes, so many thanks to the presenters. I thought it was a really excellent presentation, and the answers that you gave to Councillor Shaper's questions certainly helped me. I think the worries that I had, and I'll say what they are. I think that you know, we've got the 24 requirements laid out by the CCGs in order to find a business case acceptable, and I would like to see more visibility of the whole thing there, and a trace of where we're going on each of them, really. But I do understand that this whole thing is on a longer term. It's not just getting it all done by next spring, but you know, the full business case is really a thing. But I would urge that you do start to engage with the wider community as soon as possible. The other point I would say that I would make is that in just looking at the overall structure of that you're working with, here it is. Yeah, this is on page 4 of your paper. There's a bit of a democratic deficit there. There seems to be no mention at all of any member involvement, be that county, maybe I'm wrong, I can't see it, maybe of either county or boroughs and districts. But I think, you know, the democratic representatives of the residents should be getting involved more, and should be officially recognised. And it's a bit surprising that this is the first time that we've been involved in 3 months, or over 3 months. So that's, I think that could be an improvement, would be to move on that a bit, if at all possible. But apart from that, I thought, especially some of the later points that Mr. Fitzgerald made about setting up a reference group and the looking at Surrey in terms of buses and transport generally, is very welcome. It's very, we wouldn't want to get overlooked in Surrey. That's the point. So thank you. Yeah, I'm content, but I would like to see more democratic representation formally in the structure, and that being implemented fairly quickly. And I think along the lines of, you know, let's start with those 24 recommendations. By the way, just rambling on a bit, though, I was very impressed. I thought those 24 recommendations very fairly and accurately represented the points that were raised by the members of the joint HOSC, and therefore they shouldn't be lost. They really need to be examined and pursued. So that's, I think that, I don't know, there were questions there, but that was my comment anyway.
So may I respond?
Yes, please do, Daniel.
So on the diagram you were referring to,
Yeah.
We can make it clearer. There's a line that comes out of Trust Board, which talks about 2 external committees and organisations, where one of them is you guys, OSCs. So we are expecting to have to come to the JOSC as regularly as you would like us to come to talk about this. But I can tell you that last week I was at Sutton OSC talking to them. Next week is Epsom and Youghal Council Health Liaison Panel, where this is the topic of the agenda. So we are very happy to go to wherever you would to come and share with you where we have got to. And we could make that clearer on the picture if you would like.
Okay. Yeah.
With regard to the 24 recommendations, so that's a really salient point. So we are absolutely sure that Sarah and Claire, her equivalent in Surrey, will not provide support to our outline business case, which we have to take it to the Department of Health and Treasury, unless we can evidence that the outline business case goes through all of their 24 recommendations and sets out this is how we have dealt with them. So we look at those 24 recommendations every fortnight in the Trust to check where we are on progress in delivering them, because it is a must that we deliver on them.
Yes, so yeah, thank you for that. Okay, so I missed seeing that we mentioned on the transport bit, but it's not just transport that we're interested in, of course. You know, it's for instance how the model of care will deliver what members of this subcommittee have asked for. I mean, specifically, how people from deprived communities and black and ethnic minority groups are provided with the right level of care. So it's not just transport; it's also access in the broader sense. You know, access to services and not just getting on the bus. Thank you very much.
Good, thank you for that one. Councillor Rambash.
Thank you, Councillor Steers, for letting me ask 2 rather different questions. The first one I think is for Daniel, because you mentioned the extra 39 million for increasing capacity. And I'm a councillor, Jeremy Ambash from Wandsworth, so particularly interested in St George's, which is a very congested site as I understand it. I wonder what the plan is to increase capacity with the 40 million pounds within St George's is, if you could give me some more details.
Well, at a high level we can, but the detailed detail, that's what we're working through with them now. But the St George's will get a flow of patients from part of Merton that they don't currently get, and when the specialist emergency care hospital is at Sutton, and so they will need some more capacity in A&E. They'll need some more bed capacity, and they'll need a bit of maternity capacity. And the money enables them to expand the departments to deliver that extra capacity. Separately, they've received a lot of money for expanding critical care in response to COVID. So they don't need that bit of funding from this programme to now do that. But the assurance we need to give you is we're working really closely with them. St George's understand the impacts on them. St George's understand the capacity they need to put in place, and the money that has been allocated from the programme is sufficient for them to put in place that capacity. But when we do the outline business case, for each of the providers, they are required to fill in the same degree of templates that we have to fill in for our bits of the capital, so that everyone can be assured that it's the right amount of money to deliver the right things and in the right time frame.
Daniel, could I just, you said A&E and maternity, I understood, but what was the bed capacity for?
So some people who go to A&E then get admitted into the hospital, and so it's the beds that go with the A&E admissions.
So the follow-on, okay, thank you. That's very helpful. But my other question is rather different. Back to page 11, section 4 on the recommendations for implementing the decision-making business case. You've got one of the asterisks there about deprivation and health inequalities. and I wondered if you could say what work's been done in that area, what work is planned, and particularly the immediate work planned over the next year to address deprivation and health inequalities, because I didn't pick that up from the presentation. I guess it may be across different streams of work, but be interesting to hear more.
So I think that is a good question to ask Sarah and team when they present their part of the presentation, because it's one of the actions that they are leading on.
Okay, I'll wait with bated breath.
I haven't got anybody else wanting to come in on questions specifically. Is any councillor want to come in? If not, I'll indulge and just say, from my rather long experience at the NHS, I think you are being quite optimistic to get the outline business case in January, with a 2-week shutdown at Christmas possibly as well, and with everything else going on. So what's the risk of it moving February, March? Is there a financial risk? And what do you see as the operational risks as well?
So there is always a financial risk. So crudely, every 6 months that the building of the Specialist Emergency Care Hospital is delayed will cost an extra £5 million. And that's purely building construction inflation. There are indices that the Treasury have asked us to use, and the further you go out, the more inflation that you have to put into the model. Whether when you actually get to the point of letting a construction contract, the inflation is exactly what was in the model, well, that's to be seen. But broadly, every 6 months costs £5 million. I am quite certain that my organisation will not be shutting down for 2 weeks over Christmas. If it's like last Christmas, it was very busy and we were all at work. So I don't think that those 2 weeks are the risk. As you know, the government is trying to build an incredible amount of infrastructure, and our allotted time slot in the programme of the hospitals that are going through the process is the one we have agreed with them. So if we miss it, then we could be building in delay because there's only so much bandwidth of the whole of the top of government to review all these cases. But as it currently stands, we are actually on track to complete it for Christmas.
Okay, and I wasn't suggesting, Daniel, that the health service shuts down, but it could be people that you work with and you require information from. I think we all know that some organisations deem Christmas a holiday. Anyway, has anybody else got anything that they want to add to the trust delivery of this model? And I suppose, Daniel, the other thing I'd say is some might say that we've come at the wrong week. If we'd have come in the first or second week in November, you possibly have some plans if the Secretary of State has made a decision one way or the other.
Well, we're very happy to come back and update you whenever you would like that, Josk.
I think we'll have a discussion about what's appropriate to come back with added value. We just don't want to waste your time coming back with stuff that doesn't add value to the whole dialogue moving forward in the programme. Peter, Councillor McCabe, yes, please come in.
I think you're on mute, Councillor McCabe.
Right, can you hear me now?
Okay, yes, we can hear you. Yep.
I was looking at section 14 on comms and engagement, and I was really pleased to see the principles outlined there, in particular being open and honest, accurate, fair and balanced. And I think it's my experience from attending the consultation meetings in the part of South West London that I represent, that not all the local community felt that the previous process had been open, honest, accurate, fair, and balanced. And I think there is an issue of trust there. So I was surprised that nowhere in this, although Daniel mentioned it in his presentation, that the process of consultation wouldn't go ahead until the IRP reports. Why haven't you told people in this public pack, the agenda for tonight, that there has been a referral and that you will be waiting to commence that consultation until after that report has been concluded? Wouldn't that be more open, honest, accurate, fair and balanced?
Well, I have done my very best as have my team, to live up to those words in what we have said to you. And I did open the whole presentation we just gave by referring to the IRP.
But it's not in the pack. And anyone reading the papers for tonight would have no knowledge of that, because you've mentioned it verbally, but you haven't included that important piece of information in the agenda and in the presentation the public can look at before this meeting.
Yes, so in part we didn't do that because it's not our process. We're writing to you about what is our process as Epsom and St Helier to deliver the recommendations or the decision of the CCG. The IRP process is the process you have initiated, and so I thought it was right to verbally refer to it because it clearly impacts on our process, but it's not our thing. So that's why we didn't put it in the paper.
Peter, did you want to come back on there?
Well, I just repeat that, Daniel has just explained that the consultation the public engagement will wait until after this, and it might have been useful. And other members have raised the issue of getting on with it, and it might have been useful to explain to the public that this isn't going to happen because there is a process underway. Now, that coming back to many of the consultations and many of the comments that Daniel will have heard in Merton when he visited during this consultation period, people feel that there was an inevitability about this. And I just wonder if that's the same attitude of mind that exists now, that, come what may, this is going to happen. The runaway train continues to run away and nothing. And that would be a really unfortunate impression to create amongst people who already have little trust in the whole process. So I think there is work to be done, and if you don't recognise that, Daniel, then you weren't attending the same meetings that I was. Trust needs to be built.
I recognise, as we all do, the strong feelings that many people in Merton have about our proposal. I also recognise the very strong feelings that people in other parts of our geography also have about the proposal, and my job is to implement what our commissioners have decided, and no one is going to dent my enthusiasm and passion for having secured over £500 million of investment to build some fantastic facilities for the people who use our hospitals to have for decades to come. Now, I'm completely cognizant that the IRP might come along with some further recommendations of things we need to do, and if that is what they do, we will of course incorporate them. That's part of the process. So I have no problem with the process you have initiated and following it through faithfully. I very much hope it doesn't conclude with we lose the £500 million that we have secured, because I really think in the end, 500,000 people who use our services deserve to be treated in some fantastic modern buildings. And just the COVID surge that is re-emerging, we spent the last 48 hours really struggling with our building at St Helier about how to ensure that it can be fit for purpose for the number of COVID patients that we now have. And it would be really nice not to be in that place, but to have 70% of our beds being in single ensuite rooms. It would make managing infection and managing COVID much, much easier than it currently is. But
okay, Thank you very much, Daniel. I think you have another meeting to attend.
I do, one of your residents' associations, yes.
And I'm sure Peter would not want to keep you to any residents, keep you away from any residents' association. Thank you very much. Could I just come in, another one for Trevor, really? You mentioned the relationship and the dialogue with TfL. Now, one of the proposals of TfL is to reroute the 80 bus route away from the road that goes in front of the hospital and terminate it at Belmont Station. Now, some people might say that's not that far away, but when you look at the 80 bus route, it covers a huge cross section, not just of council wards within Sutton, but actually in Merton as well. It goes down to Merton Station, you know, it goes through a deprived area, etc. So what I'm saying is, we need as councillors to be very strong for our residents, but you also need to understand that maybe where they think they're coming from with the bus reorganisation, etc., might not be where you're coming from, and we do really want to see an integrated service. And I share Bill's concerns that North Surrey could be left out of the transport equation. The H1 is great, good idea, but needs much more development around the new proposed hospital site if we are to get it equality of transport and public transport at that into this new site. So I would take some things with a pinch of salt, and they say, well, we're working towards it. Yes, it might not be quite what we want as councillors, or you actually want as delivering this new hospital if it gets approved up at the Sutton site. So I just caution that, if I may.
Yeah, if I could just comment on that, Councillor Steers. So I think it's the consultation that's just been launched has been following a lot of work from the London Borough of Sutton, and it is a consultation. So I think, you know, your comments there are well valid, and hopefully there'll be a large amount of public engagement and feedback in terms of those proposals. I think it's worth saying that obviously we're not looking at having any trust services on that. We've got a small amount of services, but the main services won't be looking until 2025. But obviously there is access issues, I understand, already for accessing the Royal Marsden Hospital, and I think the London Borough of Sutton have worked with Royal Marsden around some of those changes in terms of improved access for patients and visitors. But it is very much a consultation stage, so that's what it's trying to get that feedback in there. And obviously the trust isn't running there. You know, we fully understand the need that we need to look at all of our population, so the Surrey side as well. Our commissioners are very clear to us about that, and that's part of the work that we will be doing. And again, we will be, during the course of that work, engaging with the stakeholders, with our patients or potential users around those options.
Lovely. Thank you, Trevor. Has any other councillor got any questions of the trust representatives? No. Okay. Can I say thank you very much to James and to Trevor, in order that we can move on. We're now going to welcome Andrew Dimitriades, a familiar face to us in this scrutiny committee. Welcome, Andrew. And we pass over to you.
Thank you, Chair. So I was going to give a short update on the areas of work that the commissioners committed to as part of the decision-making business case. And I'll go through each of those in turn. So the first area was around looking at the ongoing issue of addressing health inequalities. And one element of that work, of course, is part of the normal business that we are undertaking with our partners through the borough level planning that goes on. And we are continuing to try and facilitate those discussions through the refresh of local health and care plans, but also in the recovery work streams that we have, both in the Strengthening Communities programme as well as the emerging sort of equality, diversity, and inclusion programme. So that's one of the strands of work. But members of this committee will also be aware that one of the areas of further work that we said we would undertake is to do a further focused deprivation review to look at the specific residents of East Merton and North Sutton. What we agreed to do is to focus that work by asking an independent provider to undertake that work. But we also said that we would do that in partnership to make sure that we get the scope of that work right. And I think, as we've explored in brief this evening, one of the areas of concern, of course, that Merton expressed was around health inequalities. And of course, that was one of the objections that was put into the IRP referral. So we have to be mindful that whilst we want to ensure that that work is done as quickly as possible, there may, of course, be some reflection or learning, I think, once we've heard from the IRP that would need to go into that piece of work. However, it's also worth mentioning that through the Mayor's office, the London Mayor's office, that they've also asked to have an update on that work and have sought a meeting which Sarah and I will be attending later next week. And therefore, as part of that, in finalising any scope, we're obviously keen to hear their thoughts, but we've invited the two directors of public health from both Merton and Sutton to join us at that meeting. And hopefully we can then finalise the scope of that work and seek a provider, an independent provider, to do that piece of work. It may take longer than the timing of the outline business case, but we will try and get that work done as swiftly as possible, and we can give an update to the committee in due course. The other area of work that we committed to was around making sure we took on board any ongoing learning from a commission perspective, but from a system-wide perspective around COVID and any further impact on protected characteristics groups. This is very much part of the work that is being developed across the South West London system in response to COVID around the Equality, Diversion and Inclusion programme. And you'll have heard from the Trust about some of the specifics about how it's seeking to adapt the design of the Specialist Emergency Care Hospital in the future. So we will pick up any learning as we go around that. And then the final area, just to mention this evening before I conclude, is that we've said that we would be keen to explore, at the request of the two principal local authorities in Sutton and Merton who wrote to us, whether or not there would be any additional primary or community services, as well as potential mental health services that could be provided on either of the district hospital sites. So we've committed to undertaking an option-based appraisal around that to look at the pros and cons of the options that could be provided. But again, that work can only be concluded in an outline basis by the time the outline business case is produced, because any further new service proposals would clearly need to be developed up in more detail, and therefore might need to be considered as part of the full business case that the Trust would develop after Christmas. We're still very keen to explore what options are available around that, but it would have to be dealt with through a proper process. So that's all I wanted to say tonight, Chair, but I'm happy to pick up any questions.
Colleagues, has anybody got any questions? Yes, Councillor Shaper.
Thanks, Chair. Hello, Andrew. Thanks for the presentation. It was really just a general comment that there's an amazing opportunity. I'm sure everyone would agree that there's an amazing opportunity here with this approach of the community service and the primary and the community service element to really have, and this is just my opinion, some kind of really state-of-the-art or really sort of cutting edge centre to tackle obesity. Because the reason why I'm throwing that in is because it's obviously one of the 5 key public health elements at the moment. And we're talking about it a lot. And, I think, the linkage with other health related issues that it comes with, and also, with diabetes and all other aspects, exercise and health and so on. I think we've got an amazing opportunity to feed in ideas that we can really be quite adventurous, perhaps, if we can, and have a vision for what we think a community, a primary care and community service could look like. And I just thought, we have centres of excellence at Epsom and St Helier, and with the renal service you have and the recent expansion of services that you're providing at Epsom and St Helier in other areas. And I just think we just got a wonderful opportunity. I just wanted to feed that in, really, just to say, wouldn't it be amazing to have some kind of, research centre dedicated to, obesity and other health-related issues that come from obesity issues. So I just wanted to feed that through, and I think it would be fantastic for that to be explored. So I don't know whether you've got any comments on that. Thanks, Andrew.
Okay.
Did you want to comment, Andrew?
No. So we welcome any input, really, I think, around any suggested areas that we might want to consider as part of that appraisal. One of the things I think, Anita, we've got to balance up is what things absolutely make sense to put on a district hospital site versus what we should provide within existing primary and community service centres. Although I do know that one of the things that we will have to consider is whether or not, from a primary care perspective, it makes sense to co-locate some of those more modernised primary care services on the district hospital sites in the future. So I think we've got to weigh up the pros and cons of it, but absolutely recognise the importance of not just addressing obesity, but ensuring that we've got state-of-the-art services for diabetes, hypertension, smoking, alcohol, all of those things which are key to improving the health of our.
I mean, it was just a question of, if I may, Chair, it's just very briefly, it's about interdependency, it's also about pathway, it's also about early intervention and prevention. And if you want to try and, if we look, if that public health agenda is to look at start well, live well, age well, we've got an amazing opportunity to really make that a tangible thing for residents to understand. And I think to visualise something like that and to have a vision for it, I'm really, that's a very exciting prospect. And I think I'd be really interested as your business plan emerges in more detail, that I'd really like to see that real sort of engagement element coming through, where you could really look at health issues much earlier on, and really looking at that health prevention element of it. So, as I say, you can probably tell how enthusiastic I am. It's my background, but I do think a lot of aspects like mental health are also linked into that as well. And I think it would be amazing to have some centre of excellence located, if we can do it, as you say, at our district hospital sites. So that's all I wanted to say. Thank you.
Thank you. I suppose looking at the outline plan and I still am really worried, listening to Anita, listening to you, Andrew, listening to what we could be doing, that the outline business case is 13 weeks away. My concern is that people looking at that outline business case, we won't have had, and I talk about we as the residents, the health providers, the care providers, the representatives of the people, we won't have had time to get together and actually put some real meat on that bone for the outline business case. You know, the full business case has got to be in by November. But what we really need to do is make those people aware, and I look to people like Sarah and yourself and Daniel, to actually be saying, and the council leaders to be saying, there are other things that are coming. If you want us to stick to this deadline, as Daniel said, you know, that's our slot almost. They've got to realise that that slot is imposed upon us. It doesn't give us the opportunity to actually put our best case forward with the benefit of our residents, the patients, etc. So I think it's become on all of us, whatever channel, to actually put that up through the system and say the timelines might not give us the best outline business case, but you must realise that there could be some very, very good benefits coming as we move maybe into April, etc., etc. So I just think that we all need to work together on that one to actually get through to the echelons as it goes up the chain, to actually understand that maybe not the best case, but actually lots of stuff is on the periphery that is going to make it even better. And I've got silence on that one. You know, I will assume that silence implies assent, that we will all make our best efforts to actually make those people that are making this decision in the Treasury, etc., to actually understand that it might not be the best case we can deliver because of time constraints, but out there's a huge opportunity. I see it as a live document. I think that's what we've got to start saying to them. It's that moment in time, but it is a really live document. And for me, that's Daniel and his colleagues really coming in and saying, it is live. You know, can we feed this in, or can we feed that into it as it moves forward? And obviously supported by our CCG colleagues.
So I think that's right, Colin. So I think you have to look at the whole process as a complete process, not just the outline business case, but the full business case. It is an investment approval process. It's an iterative process, and those other things that commissioners have agreed to look at further, of course, will have to be considered in the overall planning process. We can't rush those things, but equally, we're very, very keen to make sure that, pending the IRP's response to Secretary of State, that the Trust makes as much progress as it can do in as considered way as possible. And I do know that the Trust is making every effort, as we hear, Sarah and I hear at the Strategic Oversight Group, to do all things properly.
Thank you. I'll come to you, Peter, but Andrew, it's also beholden on the CCG. You're taking some actions as well. Absolutely. You're setting up the independent review. So it's, as I was trying to emphasise, it's beholden on all of us with all our various channels. Okay.
Yeah.
Peter, Councillor McCabe, please come in. You're on mute, Peter.
Thank you, Chair, and thank you, Andrew. I was listening to what you were saying, and then you reached a point at which my connection started to go funny, and you sounded a bit like a Dalek. So I wasn't.
That was me normally, Peter, I think.
Sorry?
I think that was me normally. I'm not sure at what point.
No, I wouldn't hear such things said about you. But what I did want to be clear about is you talked about the sort of assessment of the impact on deprived communities, and it was just at the bit where you were going to say when it would be finished, I think, that I couldn't kind of follow it. So could you tell me when will this be finished? Is my question.
So we want it finished alongside the timing of the outline business case production. So our ambition is to get that done by December, and I'm hoping that if we can conclude the final scope of that work, then that work can take place during November, and it can report in early December at the latest.
And will it come to us?
It will depend on the timing of when the committee next meets.
Well, I think from myself, I'd be very, very keen to have a discussion about it, and I suspect there will be other members of this committee. I can see Anita nodding. we'd be very, very pleased to receive that and a presentation, please.
Thank you. Yes. Okay.
I was going to go on to discuss the next meeting. I will discuss it with with councillors on this committee and CCG and trust colleagues as well. There's a few milestones in this journey, one coming up at the end of the month. It could be a simple yes, no, or it could be there's lots of different things that Secretary of State would like doing. So I see as soon as we know what the decision is, certainly us as councillors will be working together to get quite an early meeting. I agree with you, Peter. We need, but not too early that we haven't got something to discuss, but actually a meeting either side of Christmas, maybe mid-December. Let's see what your proposals are from a CCG point of view, and then we'd like to call a meeting at appropriate time, but not wasting too much time. We need to move this forward at pace if we're going to have an opportunity to influence the outline business case with some of our thoughts. Has anybody else like to any questions, etc.? Colleagues, thank you very much for this meeting. Yes, Phil, did you want to come in?
Yeah, yes, please. Yes, with regard to the work on deprived communities, you mentioned, this is a question to Andrew, really. You mentioned that you'll be going to see the Mayor of London or someone at that level. And that you'll be taking along a couple of the public health people, I think from Sutton, and I presume Sutton and Merton. How do you propose to get a Surrey viewpoint on it, please?
Happy to take advice, really, Bill, on this. I think because the review was specifically around East Merton and North Sutton residents, that's been the large focus, but absolutely not to the exclusion of Surrey. I take your point.
Thank you. Yeah.
Right.
Could I leave it with you, Andrew, to talk?
Bill.
Yeah, if we take that offline, Andrew, and you can talk to Bill.
Yes.
Yeah.
Thank you.
Thank you for that. Thank you. Anything else, colleagues? Anybody wants anything? Okay, that closes item 5. Item 6 on the agenda is any urgent business, which I haven't got. Thank you for tonight. So the meeting's closed. I make it by my computer anyway, 21:03. So thank you very much, but Councillor.